So hello everyone, let us discuss about the concept of bone marrow and hemopoiesis. First of all, you should know what are pluripotent stem cells. So these cells in the bone marrow, remember these pluripotent cells can develop into any type of the blood cells. Now these pluripotent cells, it can give rise to two type of multipotent stem cells. That can be non-lymphoid stem cells, non-lymphoid and lymphoid stem cells. Now remember that the non-lymphoid cells, they differentiate into bone marrow and they form the red blood cells, granulocytes, a type of WBC, monocytes and macrophages. Whereas the lymphoid cells, they can differentiate into bone marrow and migrate to lymphoid tissue to form B cells, T cells and natural killer cells. Remember, the non-lymphoid stem cells are the erythrocytes that are responsible for oxygen transport, granulocytes. The granulocytes include neutrophils, eosinophils and basophils that are involved in a immune system. So when they enter the tissue, they differentiate into macrophages, forming a part of mononuclear phagocytic system. The platelets, they play an important role in blood clotting and maintaining the integrity of the blood cells. Now the lymphoid stem cells, remember, they produced antibody as part of, they produce B cell, T cell, NK cells. The B cells, remember, the B cell, they produce antibodies as part of their adaptive immunity. The T cells play a role in cell mediated immunity. The natural killer cells, they play a role in innate immunity. We have circulating, fourth is the circulating blood cells, RBC, that are the erythrocytes. They have an average lifespan of 90 to 120 days, whereas the platelets, they have a lifespan of around 10 days. Coming to the hemopoiesis during development, so that can occur either in the embryonic stage, infants or adults. In the embryonic stage, remember, the initial site is the yolk sac. So the initial site of hemopoiesis in first few weeks is the yolk sac, and in third month it's the liver and the spleen and bone marrow by fourth to fifth month and become fully active by the 7 to 8th month. Whereas in the post birth bone marrow, remember, it's the In infants, the bone marrow is the primary site for blood cell formation. So remember, during childhood, the hemopoietic activity become confined to the central skeleton and proximal end of the long bones. In adult, remember 50% of bone marrow is fat. In pathological condition, non-hemopoietic marrow, liver and spleen can resume the hematopoiesis. So remember that in for embryonic hematopoiesis, the blood cells first appear in a yolk sac from the primitive stem cells, and by the third month they rise in the AGM region, that is aorta, gonad, mesonephron region, and they migrates to the liver, and by the fourth month it migrates to the bone marrow. In infants, site of hematopoiesis, primary site is the bone marrow, and in adulthood the hemopoietic activity it is confined to the axial skeleton and proximal long bones. Now remember hematopoietic stem cells, they are important for the blood cells formation throughout the life. Now they have a unique property. There are two stages of hematopoiesis. The first stage is proliferation. So these hematopoietic stem cells, they will undergo mitotic activity to expand the population of their stem cells. Then they will differentiate. The second stage is differentiation. They mature into specific type of blood cells. Differentiation lead to formation of various blood cell types like erythrocytes, leukocytes, thrombocytes, etc. Now the property of hematopoietic cells is protein expression. So they have a surface marker protein, that is CD34, that is used to identify and isolate these cells. Apart from that, remember these cells, hemopoietic stem cells, they have ability to self replicate, maintaining their population throughout life. So this property makes them the ability for the lifetime production of blood cells and recovery after the injury. Other feature is that bone marrow cells, they can be transplanted. They can be harvested and transplanted into the recipient sites. The transplanted can home to recipient bone marrow, proliferate and differentiate into the various blood cell types. So it is used in treatment of various hematological diseases like leukemia, lymphoma and aplastic anemia. Now they have various differentiation pathway. The lymphoid progenitors that differentiate into B, T and NK cells. The non-granulocytes progenitors, they produce neutrophils, eosinophils, basophils, monocytes. The erythroid progenitors, they produce the red blood cells. Megakaryocytes, they are the source of platelets. Now let us discuss the bone marrow examination. So Examining the bone marrow, it is an important diagnostic tool for various hematological conditions. So various bone marrow examination that we can do is, one is bone marrow aspiration and other is bone marrow aspiration and other is trephine biopsy. So what is bone marrow aspiration? Remember, bone marrow aspiration, it is a procedure that is used to collect a small sample of liquid bone marrow using a special needle. That is, here we use is this needle, and in trephine we use is Jamshidi trephine needle. So in the bone marrow aspiration, the purpose is to examine the type and number of the blood cells in the marrow and diagnose the various blood disorders like leukemia, anemia or infection. How it works? A doctor insert a needle into this. These are the sites where the doctor would insert a needle into a bone, usually the hip bone. So they withdraw a small amount of the liquid marrow. The sample is then spread on the slides and examined under microscope. So detailed information about individual blood cell type that helps you to understand any abnormality in the cells. Whereas the trephine biopsy that is a procedure that is used to remove a small core of bone and marrow tissue using special needles. So the most common site is posterior iliac crest. So doctor uses a different type of needle to extract small slender of bones and marrow. So the sample is processed and examined under the microscope. So this trephine biopsy, it is used to determine the structural issues in the marrow. So remember, for bone marrow biopsy, the most common sites are sternum, posterior iliac crest. Whereas in trephine biopsy, the posterior iliac crest is the preferred site as it provides a sufficient amount of marrow that would be available for the architectural examination, and it is easily accessible. The instruments we use is, these are the instruments that we can use is timings. Bone marrow aspiration is quickly within 1 to 2 hours for the urgent diagnostic needs, whereas trephine biopsy takes around 1 to 7 days. The bone marrow biopsy, it provides excellent cellular details allowing the individual cell morphology details, whereas the trephine biopsy, it will give you a view of the marrow architecture pattern and identify the fibrosis, infiltrate, etc. Aspiration biopsy, remember, it is indicated for condition like anemia, leukemia, polycythemia, right? Whereas the trephine biopsy, it is indicated in cases where additional information is needed, such as in case of myelosclerosis, aplastic anemia, and when aspiration results in dry tap. That means there is failure to obtain a sample. So it is useful when architectural assessment is necessary. The erythropoiesis, it is the formation of new red blood cells. So it is a process through which the new red blood cells, that is erythrocytes, they are produced, that occur in bone marrow, remember, involving different type of cells. Now let us discuss the step one by one. The first cells, they are the proerythroblast. Remember, the earliest recognizable cell in the erythroid series, they are the proerythroblast. So remember, they have a size of 15 to 20 micrometer. Apart from that, they are the earliest recognizable cells in erythroid series. They have a blue cytoplasm due to the higher RNA content. They contain large central nucleus and they undergo 4 to 5 divisions to produce 16 to 13 RBC cells. They undergo differentiation and maturation, involving the next stage, that is basophilic erythroblast. The next stage is maturation. Here, the basophilic erythroblast, they have a size of 12 to 16 micrometer. They have a large nucleus that is more condensed than the pro-erythroblast cells. The third are the intermediate intermediate erythroblast. So they have a size of 12 to 16 micrometer, and the cytoplasm, they have so they contain a mix of blue RNA and pink hemoglobin. So they have a basophilic nucleus. The cytoplasm is polychromatic. The next stage is the orthochromatic erythroblast. They are 8 to 12 micrometer, and they have a small condensed nucleus. So pycnotic condensed pink cytoplasm due to high hemoglobin content. The next stage is of reticulocytes. So there is no nuclei. It contains ribosomal RNA, and it continues to synthesize the hemoglobin. It spends 1 to 2 days in bone marrow and 1 to 2 days in a peripheral blood before becoming a biconcave red cell. Now they can be identified using dye like methylene blue. So erythropoiesis, it is a production of red blood cells from the stem cells in the bone marrow. The stages starts from the pro-erythroblast, progress through the basophilic erythroblast, polychromatic erythroblast, orthochromatic erythroblast, and ends as erythrocytes. Ends at reticulocytes. The reticulocytes, the immature red blood cells that matures in the spleen and indicate the bone marrow activity in the producing new red cells. Now let us discuss the role of erythropoietin in red blood cell production. We know erythropoietin, it's a hormone that plays an important role in regulating the production of red blood cells. So remember, erythropoietin would stimulate erythropoiesis. It stimulates the bone marrow to produce more red blood cells. So the primary site of erythropoietin, remember, it's in kidney. In response to low oxygen level, and in certain condition it can be produced outside the kidney. Remember, the patient who have a chronic kidney disease, they have a lower level of erythropoietin that lead to anemia. The patient who are with renal cell carcinoma, they can cause increased production of erythropoietin that results in erythropoiesis. Now remember that the normal erythropoietin level, they are normally between 10 to 25 unit per liter. Now this erythropoietin, it can be measured through various tests like ELISA test and radioimmunoassay test. Now let us discuss about the morphology of red blood cells. We know that the normal red blood cells, they are biconcave disc. They have a mean diameter of around 7.5 micrometer. The hemoglobin, remember, it is concentrated around the periphery of cell, creating a central pillar that constitute around 30 to 35% of the cell diameter. So let us discuss some terminologies. The first is normocytes. Normocytic, the red blood cells that are of normal size, we denote them as normocytic. If they have a normal color, we denote them as a normochromic. That means the red blood cells, they have normal color, indicating there is normal hemoglobin content. If the size is increased, then the term we use is macrocytes. So diameter greater than 9 micrometer is macrocytes. Microcytes, when the diameter is less than 6 micrometer, then we denote them as microcytes. Other condition is hypochromic. When the red blood cells, they have area of center pillar, it is greater than the 50% of cell diameter. That indicates a low hemoglobin content. The term we use is hypochromic. When there is a variation in the size of red blood cells, term we use is anisocytosis. When there is a variation in the shape of red blood cells, term we use is poikilocytosis. Also remember that the characteristic of mature erythrocyte is that they The mature human erythrocyte, they don't have nucleus. They lack the typical cellular organelles that are found in other cells. They have a biconcave disc. So this biconcave thick disc that would allow them to be flexible, and that is why they can pass through capillaries as small as 3.5 micrometer in diameter. And overall 90% of weight of erythrocyte is hemoglobin. Their lifespan is 120 days. Remember that. Now let us discuss some red cell indices. The first is the mean cell volume. What is that? The average size of red blood cell. Its normal value is 82 to 96 cubic micrometer. Low MCV indicates that the red cells, they are usually smaller than the normal, that is microcytic anemia, and high MCV indicates that the red cells, they are larger than usual. The term we use is macrocytic anemia. The mean cell hemoglobin, what is that? It is the amount of hemoglobin in each RBC. So the normal range is 27 to 33 picogram. The low MCH means less hemoglobin is present in each red cells. The term we use is hypochromic anemia. And if it is high, that means more hemoglobin is present in each red blood cells. The term we use is megaloblastic anemia. Other terminology is mean cell hemoglobin. That means average amount of hemoglobin that is present in each red blood cell. The other is mean cell hemoglobin concentration, that is MCHC. What is that? It is average concentration of hemoglobin in RBCs. The normal value is 33 to 37 gram per deciliter. High MCHC means that it is often seen in conditions like hereditary spherocytosis. Other terminology is red blood cell distribution, that is RDW. So that means when there is a variation in size of red blood cells. So high RDW is seen in condition like iron deficiency anemia. Other is hematocrit or packed space volume. So the percentage of blood volume that is occupied by red blood cells is hematocrit. In men it's 45% and in women it's 42%. Low hematocrit means there are fewer or smaller red cells seen in anemia, and high hematocrit means that there are larger red cells as seen in polycythemia. Other is the reticulocyte count. Reticulocyte count is the number of young red blood cells in the blood that indicate new red cell production by the bone marrow. So high reticulocyte count means that the body it is producing more red cells in response to anemia caused by either blood loss or destruction, whereas low reticulocyte count means the body is not making new red cells, and it is seen in conditions like vitamin B12 deficiency. So reticulocytes count measure the percentage of immature red blood cells in the blood. So it shows that it is an indicator of bone marrow activity. It shows how well the bone marrow it is producing red blood cells. Reticulocytosis is defined as increased RBC production, and it is seen in conditions like anemia due to blood loss, acute blood loss or hemorrhage, sickle cell anemia, thalassemia, hemolytic anemia, glucose 6 phosphate deficiency, post splenectomy. Whereas reticulocytopenia means when there is a decrease in RBC production. Conditions like chemotherapy, aplastic anemia, iron deficiency anemia, vitamin B12 deficiency, pernicious anemia, bone marrow malignancy, and anemia of the chronic diseases. Now let us discuss about the symptom of anemia. What are the general symptoms? One would see is tiredness, feeling unusually tired. There is feeling of fatigue, getting tired quickly with little efforts, muscle weakness, lethargy. In older patient, there may be cardiac failure. The heart is unable to pump blood. There may be angina, chest pain due to reduced blood flow to the heart. There may be intermittent claudication, pain in the legs while walking. There may be visual disturbances. The sign of anemia is one could see is the pallor, especially the skin, mucous membrane, conjunctiva, etc. There could be cardiovascular system changes, that is increased heart beat, collapsing pulse, cardiomegaly, enlarged heart. There may be mid diastolic flow murmur, a heart murmur that is seen in the middle of the heart pumping cycle. There may be, apart from that, there may be dyspnea on exertion, congestive heart failure. The heart is unable to pump blood effectiveness. The heart effectiveness reduces. Apart from that, there could be central nervous system changes like fatigueness, dizziness, tinnitus, drowsiness, numbness, and tingling. Ocular eye involvement could be there. There could be retinal hemorrhage, menstrual disturbance, loss of libido. There may be renal system, presence of protein in urine, There may be GIT symptoms like anorexia, loss of appetite, excess gas in the digestive system, that is flatulence, nausea, feeling like you vomit, constipation, difficulty in passing stool, weight loss, unintentional loss of weight. That could be all. Now remember this formula for calculation of red cell indices: the mean corpuscular volume, the mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. Remember the formula and their value. Remember MCHC, it is independent of red cell count and size. The low MCHC means iron deficiency anemia, and normal MCHC is condition, it is seen in megaloblastic anemia. Now we know that talking about the red cell membrane, we know the membrane had three layers: the outer protein layer, the middle is the lipid layer, and inner is the protein layer. The proteins, remember, are band 3 protein, glycophorin, and cholesterol. So the proteins, they are band 3 protein, glycophorin, and spectrin. Whereas the lipid are the glycolipid, phospholipid, and the cholesterol. Apart from that, you can see is carbohydrate. It forms a lattice-like network attached to membrane inner surface. So that would give a red cell its biconcave shape. Now remember the disorders when the red blood cells become spherical. The term we use is spherocytosis. And when it become oval due to cytoskeleton loss, term we use is ovalocytosis. When they become spiny, the term we use is due to abnormalities, term we use is echinocytosis. When they become oval shaped, they become bowl shaped due to inner membrane expansion, the term we use is stomatocytosis. Now what are the nutrients required for the erythropoiesis? The metals, first of iron, it is essential for the hemoglobin production, and its deficiency would cause iron deficiency anemia. Second, other metals are cobalt, manganese, they are also needed for red cell production. Vitamin B12 and folate, they are essential for DNA synthesis. Their deficiency would cause megaloblastic anemia. Vitamin C, it helps with the iron absorption. So in order to absorb iron, we can give is vitamin C. The amino acid, they make up the globin part of the hemoglobin. The hormones, erythropoietin, they regulate the red cell production. Other hormones are thyroxine, androgens. They also play a role in red cell production. We know that hemoglobin, it consists of globin and heme protein. Globin is alpha protein. Globin is a protein and heme is a iron porphyrin complex. So HbA, HbF and HbA2. HbA contains alpha 2 beta 2 units, HbF alpha 2 gamma 2 units, HbA2 is alpha 2 delta 2 units. We also know that the starting point of hemoglobin, it begins in the mitochondria. The key steps involves multiple biochemical reactions. The first step is amino-levulonic acid synthesis requiring the pyridoxal 6-phosphate. The protophyrin, it combines with iron forming transferrin to form heme. The final product is the each heme molecule combined with the globin to form hemoglobin. Now, what are the basic investigation for the hemoglobin activation? We can do is peripheral blood film examination. One can other do is hemoglobin estimation to measure the hemoglobin level in the blood. In the peripheral blood film estimation, we can examine the shape, size, color of red blood cells under microscope after staining them with special dyes. The dyes we can use is Romanowski dyes, Leishman stains, etc. So variation in the size, the term we use is anisocytosis. Normal sized RBC, they have slight variation in size. If they are larger RBCs, that are seen in macrocytosis, seen in megaloblastic anemia, aplastic anemia, liver disease. If the size is small, the term is microcytosis, that is seen in iron deficiency anemia, thalassemia. If there is variation in shape, the term we use is poikilocytosis. Increased central pallor indicates lower hemoglobin content seen in iron deficiency anemia and chronic infection. Increased hemoglobin concentration is seen in megaloblastic anemia, spherocytosis. Now some specific changes that are seen in RBC is punctate basophilia, or basophilic stippling. It is there you would see uniform granules within RBC. It is seen in aplastic anemia, thalassemia and lead poisoning. Howell Jolly body, here you would see purple nuclear remnants within the RBC. The condition it is seen in megaloblastic anemia and Ploft splenectomy. Spherocytosis, the RBC, they are spherical instead of normal biconcave. It is seen in autoimmune hemolytic anemia, ABO hemolysis of newborn, schizocytosis, That means the RBC, they are fragmented. It is seen in conditions like, remember, thalassemia, megaloblastic anemia, iron deficiency anemia, etc. Other term is leptocytosis, thin RBC seen in severe iron deficiency anemia, thalassemia, etc. Sickle cell RBCs, they are seen in sickle cell anemia. Burr cells, RBC fragments with one or more spines. It is seen in uremia. Oval or elliptical RBC, it is seen in hereditary ovelocytosis and elliptocytosis. So by examining the shape, size and staining characteristic of RBC in peripheral blood smear, healthcare providers can gain insight into the type and the cause of the anemia. So this morphological analysis, it is complemented by other tests like complete blood count, reticulocyte count and specific biochemical assay to form an accurate diagnosis.